Well, hello and welcome to Beyond the Diagnosis with Chris and Anna, being broadcast from the BioSkills of the Northeast studio in Fall River, Massachusetts. Today, we'll be discussing shortness of breath with Dr. Mendieta and also with Dr. Anna and myself. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Bay Coast, visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And Anna, I'll turn it over to you right now then.
Yeah, thank you. So I'm Dr. Anna, Dr. Joncas, Dr. Anna Cojocaru, and Dr. Mendieta. Dr. Joncas is a primary physician. I'm a pulmonary and critical care physician. Dr. Mendieta is a cardiologist with certified also in heart failure, yes?
I have a certification in heart failure as well as cardiac imaging and echocardiography and nuclear cardiology.
Okay, many certifications.
That's a lot of certifications.
Yeah, but we're here tonight. We're here tonight to have an easy discussion about shortness of breath, and we're here to serve you, our patients in the Fall River community in the South Coast. And please follow us Beyond the Diagnosis on Instagram and YouTube, and share if you like it. And please send us questions on the email attached so we can discuss different topics and help you to navigate the healthcare system. And also we want to show you and to tell you that we're here for you as physicians and in our community with Prima CARE. So,
and just once again about the email, it will be listed, but it's Prima CARE Beyond Diagnosis at gmail.com. And we'd love to hear what you want to hear. And we'll basically make sure that those topics are discussed.
Right.
Yeah.
So, shortness of breath is one of those common things I deal with as a primary care physician. You deal with as a pulmonologist. You deal with as a cardiologist.
I love it.
And it's a really common symptom that comes up in my office all the time, and I'm sure for both of you.
Yes.
But it's very complicated. There's a lot that can cause shortness of breath. It's not as simple as one or two or three diagnoses. There's dozens, if not more, right?
And also, if I can interject,
Sure, of course.
it's one of those diagnoses that we definitely need to listen to the patient.
Sure.
Because it can come so the same shortness of breath when it's on exertion, we call it dyspnea on exertion, at rest, shortness of breath. But we were discussing before coming in today about how it's one of those chapters in medicine that is almost like fever, like something like this.
Right.
It's big, it's thorough, it has to be comprehensive,
Right.
and it has to include multiple specialties.
Right.
And
Right.
and one of the things that I find in my practice, at least, is many patients unfortunately come with a preconcept of what shortness of breath is, and many of them tell you, "Oh, I have shortness of breath because I gained weight." I usually tell the patients, please don't give yourself a diagnosis, because
I love that.
that's putting them under the rug. Let us do the work for you,
Yes.
and we go one by one. Now, usually I get patients from primary care doctors because cardiology will likely be the one to really harm you if left untreated.
Right.
So most of the times this thing starts with me or my colleagues, obviously. Cardiology is what I mean. And then it will be followed by, depending on the symptoms, pulmonary, and sometimes even gastroenterology will give you shortness of breath.
Mm-hmm.
So it has to be like stepwise approach, scenarios, and let the patient talk, because many of these things, sometimes it's just one or two hints that will give you the diagnosis. And I'm sure you've been through
The history is
thousands of tests, thousands of dollars testing, and then there's one or two things like, yes, when I'm exposed to certain things, I have this. There you go. So
Yes.
So I don't know, what do you think?
Yeah, so you're right. I like the stepwise approach. So the shortness of breath is a feeling. So our brain gets the sensor and the sensation of not being able to take a deep breath or not getting enough air, okay? So it can be anywhere on that axis, So we start usually, and we think that shortness of breath starts somewhere, in the middle of your chest or in the lung. But the lung, really in the middle of our chest, in the lung, in the center is the heart, So the heart has to push the blood to the lung and back to the heart, and the lung has to be washed not only with blood, but with air. So any kind of disruption in the air circulating in the lung or the blood circulating through the lung, it can cause shortness of breath. Those are major things that you and I are looking for, yeah?
Yes.
But there are other things that can cause someone to have shortness of breath, yeah? Let's say the wiring, the cage, the rib cage, yeah, has also issues where the rib cage is surrounded by our ribs and chest muscles, but also in the belly, separating from the belly, the chest is the diaphragm. So any kind of issues beyond the diaphragm, or even muscle of the diaphragm, which is two huge muscles, left and right, yeah, sitting on top of your belly, just on the lower part of your lung, if that muscle is not functioning correctly, which we see a lot, yeah, it could be as simple as that.
That specific condition requires a highly suspicious physician.
Yeah.
Mm-hmm.
The diaphragmatic dysfunction is not something that everybody thinks of.
Yeah.
Right.
And we find it on X-ray. So for first evaluation, I think is patients come and tell us, but I also seen patients who told me, I have this famous case. He's like patient in his 50s, now he's older, I've been seeing for many years, and he's like, I cannot breathe. He had actually sinus issues.
Right.
Mm-hmm.
Yeah. So it starts, our breathing apparatus can start in the nose and sinuses. So there are many layers.
When people say that they're short of breath, sometimes what they really mean, you have to delve into it. You have to listen.
Yes, yeah.
Because I've had a number of patients who, they're really saying is they have nasal congestion.
Yeah.
They can't breathe through their nose.
Yes.
And that they have a sensation of shortness of breath.
Yes.
Sometimes it's much more ominous than that. But
that's right.
But yeah.
I'll give you another one too. I mean, just jumping around. But in heart failure, it's very common to have something called orthopnea, right? Which is unable, or the sensation of not breathing well when you're laying flat.
Mm-hmm.
This is very classic. Usually patients in heart failure start using more pillows. This is one of the paradigms that we find in the physical examination and also anamnesis, or history and physical. And GERD does the same.
Yeah.
When you start having that reflux,
Bad asthma control can do
they can't lay flat anymore. And then
yes.
But then the question after that, what I usually ask is, do you have any heartburn with this? Do you feel like food is regurgitating? Oh yeah, doc, I've been doing this for 15 years. Okay, you and I need to talk with our gastro for now. Yeah. But yes, it's one of those things that completely off.
Yeah.
And that's probably the cause.
Yeah.
So when I
had that issue when I was pregnant, by the way.
No, but
it's a big belly.
That's a big one.
Yeah.
That's a big one.
So, yeah.
Mechanical cause.
It's a mechanical cause. That's right.
Yeah,
yes.
Absolutely.
But a lot of times I think patients start with their primary care doc and then they move on to a specialist. And then sometimes they end up back at the primary care doc. It depends. It depends what is found or not found.
I think it makes sense. I mean, the variety of shortness of breath, because imagine you can have somebody with asthma.
Yep.
But if that person has an underlying abnormal EKG that is completely independent from the symptoms,
right,
you actually need to study that to make sure that this is independent. So it's hard to tell primary cares when you see a patient for the first time. You have an EKG, I don't know, the left bundle, and the patient says, well, I'm short of breath for the last 2 months, and the left bundle is new.
Right.
It could be independent.
It could be.
But at the same time,
I can tell you how I approach it as a primary care doctor.
Yeah.
Because basically, the history is so key, because you can sometimes figure it out just by the history before you even lay a stethoscope to their chest. Sometimes you have to really be able to listen to.
Well, kudos to you guys, because to be honest, it's meeting somebody for the first time and coming with all this. It's a lot.
Yeah,
it's a lot of work.
It's a lot, and but you have to listen, and you have to. For me, I'm thinking about, okay, what are the things that are going to kill them that I don't want to do?
Yeah.
So that's the first thing.
Critical thinking.
Do they have, critical aortic stenosis, heart failure, pulmonary embolism?
We have a big mass in the back of it going, Yeah.
That's right. So you think about that stuff. But there's a lot of things that I also think about that probably aren't classic as to what we'd think of with shortness of breath. So, simple things like anemia, right? And we always rule that out. That's an important thing. And you can get fooled. You can have someone who has a pretty significant anemia, and that's the cause of their shortness of breath. There are metabolic causes too, right? So someone can have uncontrolled diabetes, be in diabetic ketoacidosis, they're short of breath. Other metabolic...
They're really not short of breath. Maybe it's a compensatory mechanism.
Hyperventilating to blow off the acid that's in their bloodstream, right?
And also, we cannot always forget about the also psychiatric conditions, right?
Yes.
And then unfortunately, stress disorders, post-traumatic stress disorders, general anxiety disorder,
even brain trauma.
And also,
They can make you actually to kind of have the sensation or the sensation and the understanding of shortness of breath in your brain,
yes.
and it can actually trigger ventilation problems. Like you can breathe fast, you can have chain stroke breathing, or the abnormal breathing patterns because of brain trauma. But it could be from a bad injury, in the past maybe. So
I think about, are they able to carry the oxygen as they need? So do they have carbon monoxide poisoning? It happens, especially in the
mold exposure.
Yeah.
Unfortunately, there was an actress who unfortunately passed away from that.
Yeah, really
exposed to mold.
Yeah.
And then unfortunately in the autopsy it was found that that's what it was. So it's very sad, very sad.
Yeah, but exactly as you said, Dr. Joncas, looking at the oxygen saturation, looking at the blood pressure,
Right, so you got to do something.
Do they have JVD?
Right.
Do they look like pale, and do they look like sick? Right. Pale could be from bad anemia. Yeah.
Right. So
they have recent travel.
Basic blood work, which will be like a metabolic panel, which will cover, kidney function, or look at their bicarb in their blood. Basically, is there
also
listed their blood.
You guys have found also a lot of patients with liver cirrhosis at some point.
Yeah.
So this one too with abdominal distension, also increasing the abdominal pressure.
And definitely a chest X-ray.
Chest X-rays, especially.
We should do chest X-ray. Listen to their lungs.
Blood count, comprehensive metabolic profile, thyroid, study of TSH usually. Yes. Those for me are very key things that I have to do. And of course, you're looking at the vitals. Do they have a fast heart rate? Are they tachycardic? Is their blood pressure normal? Is their oxygen level normal? Yes. What's their respiratory rate?
Anything changed in their environment recently? Right. Anything different in the last few weeks? What happened to you? And they start actually disclosing, we did this or we did that, or we got a new pet.
So those are some basic
got some birds.
But the history is key. What do they mean by that? Is it exertional? Is it at rest? Do they have nasal congestion? Do they wheeze? Is it when they lie down? Mm-hmm. Do they wake up short of breath and have to open the window?
I think that's going to be the most important thing for the patients because, I mean, this programs that you guys are doing is great, by the way. Congratulations.
Thank you.
It's important because right now we're talking a little medical.
Yeah, right.
We love what we do, but at the same time for the patients, it's don't stay short of breath.
Right. Yes, come and ask us.
Don't stay like that. I mean, that's not normal.
Yes.
You have to look for help. And and the idea is that you need, number one for the patients is you need to feel comfortable with your doctor because you have to tell them everything. And if I can advise something to the population that is watching this right now is make notes of what triggers it, what makes it better, when did it start, did you have asthma as a child, do you have any history of cardiac issues? Bring that to your doctor because the more information we get, the better. Let us discard the information we don't need. Some people just assume like, why would my doctor care if I have, I don't know, my fingernails are now bigger? That could be pulmonary hypertension. Right. So let us
decide.
Let us clean that list and then and tell us what you feel. That is the most important.
Sometimes patients are hesitant to bring these things forward, but they'll bring up something that is such a key piece of evidence.
Absolutely.
That it makes the diagnosis.
Absolutely.
I love what you said, Dr. Mendieta. Just for the patient not to hesitate to come and to talk to us. I'll tell you, as a critical care physician, we see that a lot of the times patients come to the hospital and is kind of late. And it's like, I always tell myself when I see patients when they come too late, like, I wish you were here 2 days ago or a day ago.
And that's on an emergency basis. But at the same time, you have these guys that say,
don't ignore.
76 years old, life expectancy in the United States, I think, is 85 for men, 87 for women.
Going down, unfortunately.
Unfortunately, going down. But my point is that, Doc, I'm getting old.
Yeah,
don't
put it on hold. No.
Why don't we?
Let me decide.
Why don't we decide?
Yes.
Time tell us if it's getting old. But there are people in the 70s saying, no, I'm just getting old, Doc.
Yeah. So shortness of breath is actually one of the most common complaints and symptoms in acute urgent visits, walk-in clinics and emergency room. And they can come with different complaints, but will have associated, may not be the number one complaint, but is very common associated with other conditions. And of course, we have Dr. Mendieta here because heart is in the middle of our chest, and heart can contribute to shortness of breath, but it's not because of that. It's because heart conditions is one of the top reasons of dying. So when somebody's shortness of breath, has shortness of breath, we want to make sure it's not a cardiac condition, but we know.
And within the heart, again, I understand this is shortness of breath, but within the heart, you have like a house, right? Rhythm problems, plumbing problems, chamber problems, door problems, pump problems, pericardial problems.
Yeah.
So it's a lot. Thankfully, with an echocardiogram, we can rule out a couple of things. With the stress test, we rule out other ones. But the whole idea is that the patient needs to approach.
Yes.
Bring this forward so we can take care of it. It's not that you need 10 tests to get through.
Yes.
But if we start with the basic, we can certainly rule out the bad things and then move forward with the other ones.
Yes, and have a peace of mind. Okay.
Yes. Our job, like Dr. Joncas said, we EKG, X-rays. X-ray, we're looking for potential dissection, potential pneumonias, pneumothorax, the major stuff.
Yeah.
EKGs, if you've had STEMI, okay, we're in trouble. But that's the whole idea, to rule out the acute things and then kind of go down the list of things that could be affecting you depending on your lifestyle and your conditions. Because this is what's key about shortness of breath. It's very individualized.
Yes.
So it has to be, your field, how many patients do you see with mesothelioma?
Yeah.
Asbestos. I think thankfully it's changing. But remember those times we were training.
Asbestos exposure.
Asbestos exposure, shipyards.
Yes.
So now it's like us, rheumatic fever is going down, thankfully, to penicillin. But we were training on that before because we saw hazards that before we didn't think it was malignant. Right. Down the line, 30 years later, here we are. You remember the commercials about doctor smoking?
Oh yeah, I don't remember them exactly. I sort of
but yeah,
you're
old.
No.
No, but did you know what I mean? I saw them. I saw them because when in my medical school they were saying, "Look, this is what we believed before."
Right.
Yeah.
And it was crazy.
This is your breath. Yeah, to take a breath.
Oh, the doctor at the end of the day prefers a camel. This is great. Right. Exactly.
Yeah.
So that's the these are the things that we have to. Every case is individual. Bring it forward. We'll take care of it.
And by the way, just to go to smoking, I tell my patients, they say, "Why don't I smoke cigarettes? I just get a cigar, or I vape, or I just do that." And you know what I say? Anything that you breathe in, that is anything but clean air, is not good for you.
Right.
Okay, only clean air should go in your lungs.
We're not designed.
Yes. Yeah. Otherwise, we don't know because a lot of things we don't know.
Yeah. Oh wait, that's a whole different conversation about the vaping.
Yeah. Acute lung injury and different exposures.
For the young population, I know this is not a topic, but please stay away from that.
Yes.
So let's assume a patient came to me and I did the history. I couldn't really tell what the cause was. I did the basic labs, an EKG, a chest X-ray. I ruled that out. I ruled out, pulmonary embolism. I don't think is too high on the list. I'm thinking, well, maybe this is cardiac. They have, they have intermittently, it's exertional, maybe a little bit of chest pain, so I send them along to you, right? Send the patient to you. Tell me how you're going to approach that.
Well, the first thing we look into, one thing that I want to also bring to the table is different chapter, but we have something called anginal equivalent.
Mm-hmm.
And that means, in women in particular, they don't present with the classic living sign, chest pain in the middle of the chest. I get that. Yeah. Right. So unfortunately, women can have heartburn, teeth pain, jaw pain, shortness of breath, and that all could be signs of fatigue as well. Many. We could open the book here, but it is important for me to get before I see the patient, and something I appreciate from your referrals is the echo's been done, the EKG has been done, so we can take it from there. Most of the times, when that is done, we move on to a stress test. A stress test in particular, and I want to use this platform also there's a misconception out there that a pharmacological stress test is better than the regular stress test. And I had patients asking me,
you mean?
No, the pharmacological meaning
but it's better
than the exercise.
An exercise.
Yes, it is true that when you compare exercise with imaging is better, but not the imaging with the chemical alone, because when you exercise, you see blood pressure response, functional capacity, heart rate response, EKG changes, what was the length of your exercise.
Are you limited by shortness of breath?
So exactly, not limiting on general. So these are things that we'd like to do, and it gives us a lot of information.
Yeah.
Because I've had
More comprehensive, of course.
comprehensive.
Absolutely.
So I want to use this platform for that, because a lot of patients come here and say, well, I like to have the chemical one. Like, well, right. Not really the case, because there I cannot see
Not the ideal.
what you're doing, how you're feeling. And we want to, I know it sounds almost like Machiavellic, but what we want is to replicate your symptoms on the stress test.
That's right.
So we can see what's happening.
Yes.
I know it sounds like you like the House of Pain, but at the same time, that's what it is.
Yes, you're absolutely right.
That's what we're looking for. So to answer your question, another thing I want to bring up is the age population also plays a role. Younger guys, let's say you're sending a patient to me that's 23 years old, having shortness of breath. Well, I'm concerned about congenital things or maybe hypertrophic cardiomyopathy.
Right.
Yeah.
But if you are above certain age, let's say 55, 50 and above, that's when the usually ischemic heart disease starts.
Sure.
So now I'm concerned about
Coronary disease, et cetera, yeah.
Imagine a guy, 50 years old. My father had a heart attack age 50. So I'm like, okay,
Yeah.
this has to be, that's the first step.
Yeah,
So the
family history is very important.
Yeah. So basically, like you said, to work up as a cardiologist, our echocardiogram is key part of our arsenal.
Mm-hmm.
Cardiac CTA is also gaining a lot of attention as a first line test too, where we can see potential blockages in the coronaries as well as LV function and also myocardial structure. Valves are not well seen on cardiac CT,
Interesting.
but echo is really good for valves.
Uh-huh.
So we start with echo because first it's cheaper and there's no way to harm you with it.
Yeah.
Our cardiac CTA involves radiation and contrast.
Yeah.
So that's, this is kind of a second layer on that. But on a young guy, why not? Yeah. MRIs can also be done, especially for patients who have a potential history of infiltrative conditions like amyloid. That's more chronic.
Yeah.
But it's something that we use for patients that are complaining of ongoing exertional dyspnea or shortness of breath, like in the topic we're using. And we have done a lot of things and nothing is found.
Yeah. Yeah.
So I will probably start with just to let you know, EKG, echo, stress that give us all good 80% of where we stand.
So what we're saying, when a patient will see you, Chris, as a primary, and you'll do the basic workup, an exam, looking at them, taking the history, putting the risks in and out. Of course, I said the chest X-ray. But another thing, if they have associated any other symptoms, respiratory symptoms besides shortness of breath, like cough or wheezing or any history of lung disease, I would say a basic spirometry, because you can look if they have any airway obstruction, And those, although full pulmonary function testing will give us a very comprehensive overview of breathing, difficulty breathing. So by the way, the breathing test has 3 parts. One is looking how air flows through the airways. That's the spirometry.
Right.
To see asthma or COPD or bronchial responsiveness. Second looks at the lung volumes. Okay, so if you have restriction or if you have stiff lung from different reasons. And the third part is gas exchange capacity, which there are many, many things that can cause issues at that level. So when we don't understand, actually we like to do those tests because it actually points out what direction we should look for issues of shortness of breath.
I like to do that for the patient.
Yeah.
Just, would you have seen it?
Yeah.
When I usually start with those, and if I don't find anything, it's a way to save patient time to the patient. I just ordered it myself. And if that's normal, then I would tell the patient, look, there's nothing here. We should probably go a little bit more advanced. And that's when I start with even a cardiac catheterization, if it is possible, to check pressures inside, or an MRI. But at least I like to, like you said, get benefit of the doubt with the pulmonary part.
Yeah. If they don't have, of course, any associated respiratory symptoms like cough and wheezing or history, of course, shortness of breath now, it can be really more difficult. But even sleep apnea, obesity and sleep apnea, it can make people more short of breath during daytime, significant weight gain.
Sure.
Or now, actually, let's bring up all of the new modern stuff, GLPs,
Yes.
It causes muscular atrophy, and it can cause actually shortness of breath. So when you lose muscle strength, then what's going to happen, actually, you can get the sensation of shortness of breath because you get fatigued.
Yes.
Yeah? Also, GLP-1s can cause delay in gastric emptying. It can cause more reflux.
Sure.
So these people can have more maybe distension in the stomach and the sensation of fullness in their stomach pushing up. And then if you're older women, for example, or an obese patient, a little bit extra weight, then they can have hiatal hernias. And hiatal hernias can be basically part of your stomach is traveling up and it sits partially in your chest and is pushing.
Who required surgery because they had
And
the good thing about the cardio CT
yeah.
is you can see, well, good news, your coronaries are great. Bad news, you have a hernia.
Yeah, you have a stomach sitting right in the chest.
Part. So then it can also
push all the structures around, and the sensation of shortness of breath comes from that.
And that's the good thing about the testing that we do. That, for example, the cardiac CTAs will get part of the lungs.
Yes.
So we can at least start looking into all the directions when this test overlaps.
Yeah, I think what's good from my perspective, if I think maybe it's going in a cardiac perspective, and I send a patient to you, and you rule out all the cardiac stuff, then, you'll refer to pulmonary. If I think it's maybe pulmonary and I go to you, and you'll make a referral to cardiac if you don't find it.
We do.
Between the three of us, we can figure this out.
Yes. And sometimes you're right. Like I do a lot of referrals back to GIs, for hiatal hernias, and they need, I have a bunch of people who needed surgeries, as you said, and they feel so much better.
That's the multidisciplinary approach.
Absolutely.
So the good thing is there's no reason you do one thing, send back.
Right.
This is just...
Yeah. And what we need is for the patients to know that they can trust us, they can rely on us, and they have to trust their primary physicians. They have to go back and say, listen, I've seen this doctor that you referred, but they didn't really give me an answer.
Right.
Can you tell me more, or we cannot just dismiss them? And sometimes when we rule out major issues and we don't see anything palpable or something that was really life-threatening, then we can look, into other things like deconditioning,
Yes.
We can.
Those are the patients that I like to let them know, because they come with, I don't like when they come with a diagnosis thing, meaning, no, it's because I'm old. I understand that's called physical deconditioning, but I take my time to explain them that this is a diagnosis of exclusion.
That's correct.
It is.
Means we have to make sure the rest is fine before you say this.
And before we allow you and tell you go and start exercising, and they will get short of breath. Patients will tell me, say, listen, you've seen your cardiologist, you've seen me. It seems that we don't see anything, nothing is 100%. Nobody can guarantee you anything.
Right.
But we don't see at this point anything life-threatening. We want to build up on exercise, even in older patients. I'm like 5 minutes before you start eating. You eat 2 or 3 times a day, 5 minutes of exercise. What does it mean? Take a few deep breaths, get a better posture, like you have to exercise your upper body, lower body, sit-ups, I don't know, hold into something, lift your legs,
the good
basic things.
And the good thing is that it's free.
And it's free.
And
That's
it's
right.
free. So, you can just...
Yes.
At the most, what I tell my patients is, and we can use this platform for that too, I understand the American College of Cardiology likes cardio exercises, but there is a misconception between the 10,000 steps a day. That's just the difference between sedentary and non-sedentary.
Right.
But riding a bike on the streets, cars, accidents, jogging, ankle problems, knee problems, hip problems. So I usually ask them, get it yourself, if you can, a stationary bike or even a rowing machine.
Right.
Where you can do this 15, 20 minutes.
Yeah.
Notice a difference. Yeah. I'll see you in 6 months. They lose 10 pounds. I said, dog, you were right. I feel a lot better. I'm on my way to do this. Your blood pressure is better. I said, dude, just go with it. I'll see you next year.
Yeah.
So but the idea is that
it's consistency.
I think
one step further.
One step further. And then the thing is that I don't believe we have done a good job at telling the patients what kind of exercises they can do. Because some people I've met people that are in amazing physical shape. They still weightlifting in their 70s.
Yeah.
But that's actually not cardio.
Right.
So
yes,
we have to educate people on it is not only lifting weight. You have to keep your cardio is defined as heart rate above certain number. We can go over that later. Continuously, at least 20 minutes.
Yes.
3-4 times a week. So, but then they say, but doc, I can barely walk. But I just gave you exercises that are at home, stationary, you're safe. Do something.
Yeah.
So that's something that we use a lot in physical deconditioning.
One of my patients, actually an older patient, recently told me, she's like, doc, one of my friends said that she has this little pedaling thing.
Oh yeah.
And she started pedaling and she said, look, my legs they're like 30% less swollen. She's like, they were big like this, and now they're much smaller. Since I've been doing this for like 6 weeks, and I love it, doctor. I love it. I watch TV and I just use that. An older patient who doesn't have very good balance, who's at risk of falling, we have to adjust, yeah? And that's, I think, a lot of primary care physicians' job, which is very hard, actually, to get the patients to buy into that, but saying,
I understand also the financial play a role. I mean, you have someone on a fixed income, ask them to get a rowing machine at $200, it's maybe, but I just feel it's hard. We have to be conscious and mindful of that. But whoever can or something, those are the real cardio exercises.
Yes.
Or if they can have another one of the big ones is swimming. Yeah. Obviously, swimming at that age, I'm careful, but swimming, you can go to a local gymnast. It's
YMCA here in Fall River.
Whatever they can go. Swimming is one of the big ones.
Yes. I actually had a consult years ago. Was this lady in her late 80s came to me for difficulty breathing and the inability to swim.
There you go.
As long as she used to.
Okay. That's a good.
So it was really like, and to me, she was losing muscle strength and all of that. But it was interesting. Some patients are really in good shape, until
it's very nice to see
their
that.
age. Yes. It's a good consult. I love seeing those.
Yeah. I do get a lot of patients who I recommend exercise to, and they're older and they're afraid to exercise because they haven't really done it, and they're afraid they're going to, have a untoward event, a heart attack or whatnot, a stroke or whatever it may be. They're concerned about that. What do you say to those patients? Let's say someone's a 65-year-old and he's never really done much for exercise.
It's a great question. It's a good question because
what do you do?
I tell them to start slow. This is not a competition to go to the head of the Charles. This is not Boston Marathon. You're going to start with 10 minutes. You feel good? Move on to 15 the next week.
I love that.
Then the next week, 20. And when you feel that you can, let me know how much you achieve. If you achieve 30 minutes, you're doing great.
That's pretty much what I tell patients, but there's
you go slow step by step.
Something limiting, they need to bring it up to you.
Exactly.
Right, if they're having symptoms that are limiting what they're doing. But I have a lot of patients now, and I don't want to get too far afield of what we're talking about, but they want to have like cardiac calcium scores and that.
Oh, that's a good.
Because they're concerned that they have underlying coronary artery disease that has been undiagnosed.
Yeah.
So what do we do with
I think that's a separate topic, but you're right. It goes a lot with this. It's primary cardiology, primary prevention, basically.
Mm-hmm.
And nowadays, the American College of Cardiology is asking people to, I'll give you one example. Have you seen those patients with normal LDL, normal cholesterol, and they still get a heart attack?
Mm-hmm.
Of course.
So what are we doing? So now we have a standard lipid profile and an advanced lipid profile.
Mm-hmm.
So the American College of Cardiology is asking people to check lipoprotein A.
Right.
I'm actually getting, those cases apart because there's maybe therapy coming out. The only thing that works for this is the PCSK9 inhibitors. And what we like to do with those patients is a standard lipid profile. If it is significantly elevated, you have to consider familial, but you also get apolipoproteins. You can also get lipoprotein fractionation, which is the LDL, if it is big and fluffy, is not going to any excess LDL is bad, but the big one is less likely to cause harm because it doesn't stick on the endothelium. So the small one is the one that gets sneaky on the endothelium and builds the plaque.
Okay.
So we can do lipoprotein fractionation. I usually do that for patients who have normal LDL, and they still have calcifications. And why are you building calcium like this, plaque?
Yeah.
You do that and the LDL is very small, and that's the one that you want to. Yeah. So for calcium score, to be honest, anybody who has a family history should consider that.
I think age is important.
At the age 45.
Okay.
45 and above.
Okay.
But if you have a family history, you should probably start early.
Okay.
That's an age that probably is
Women
questionable.
and men?
Both women and men.
Oh, wow.
But the family history differs in women. Women is defined as less than 55, men less than 45. So that's a different story. And in terms of the family history.
Okay.
But I believe probably everybody about 45 should get at least a calcium score and consider checking their cholesterol.
It'll become as we do with colonoscopies and.
I think part of the lipid profile will include the lipoprotein A at least once in a lifetime. Because if you don't have that problem, you'd have to recheck it.
Right.
If you have it.
Ruling out.
Yes, because it's a pathway that is defined by your genetics.
Uh-huh.
So if you have that problem with that pathway, then it will be positive, and then you'll follow it because now we'll have therapy soon.
Soon. So let's say you will test that patient and you will find a problem. You say that will be a treatment. But is any risk factors? Would you test anyone, or is only
At least
ones
once.
that have?
No. Everybody should be checked at least once in a lifetime.
Lipoprotein.
Yes. If it is normal, done. If it is abnormal, well, now you're going to have therapy and you're going to follow it.
Yeah, we don't have it yet.
Well, it's pretty advanced. Phase 3 now.
Okay, so patient.
And PCSK9 inhibitors do work on it.
Oh, okay.
But there is one coming specifically for that.
Okay.
It's like atorvastatin that can lower triglycerides. But to be honest, PCSK9 does work on it. But again, there's another one coming soon.
Great. That's great.
Yes.
So all of these new therapies that are coming out there, we barely can keep up. I'm like board certified in internal medicine, but I took it a few years ago, and I was like, you barely.
Preventive care
is just so hard. Yeah, I have to say that being a primary care physician, I feel like it's much harder. That's why I became a specialist.
I think
they're all hard. All these fields are hard in their own way.
Yes. If the medicine became so specialized, it's so much information that we really have to rely on each other, on helping each other to understand the patient. Yes.
Effort, one man army.
Yeah, you can't have one person that does it all.
But we have to say that the patients will have to take it in their hands. If they really have issues and they don't feel like they get answer, they can come back to their primary and say, doctor, in a nice way. Because we all can miss things and we can look things, but you are the guardian of your own health. Yeah.
Right.
You as a patient.
What I demand from the patient is just tell us everything. Let us discard what we don't want.
Yeah.
And we have on our part, we have to listen. We have to be good listeners.
Exactly. Yes. Yeah.
And it's harder all the time because we have this thing in between us, the computer. That is the interface now between our patient.
I know that's a long conversation. I usually bring my computer just to bring labs, but I usually don't because it's tough, right? It's
I used to do all typing. Now I just use AI to help
exactly
history, and it's much better that way because I can make eye contact.
Exactly. Go back to the old thing.
Yeah, then make that connection that you lose when you're just typing. I still have to do a lot of typing. I have to correct things.
Yes.
I overread it, right?
Yeah.
You have to read everything that is written there, of course, and you still have to input orders and do this and that.
Yeah.
But still, it's better than it was previously when you're just typing the whole thing out.
Yeah. So for the patients, if you have shortness of breath, it's very common. It can be many issues. You should bring it to your primary physician if it's persistent. When is it present? Is it anything changed in your life? Did you have a travel? Did you get a cold? Do you have cough or any kind of...
It's not normal. Any new shortness.
Any.
Bring it forward. Don't assume it's because I'm getting older, or
yes,
I'm a little overweight, or whatever it may be, because there could be something very serious that's underlying that needs to be resolved.
For the patients listening to this, I would say that any acute symptoms, don't wait.
Out of a sudden meaning, if it's sudden.
Don't wait.
Don't wait.
Don't wait and go either to the nearest emergency department or ambulatory care. But something that is sudden or also progressing to the point that you cannot function like you used to function 2-3 days before,
right?
Pay attention.
Yes.
If it is something gradual, okay, fine, talk to your PCP. But the other ones, don't sit on it.
All of a sudden you wake up, you're short of breath, or the course of the day you develop sudden shortness of breath.
Yes.
There's no reason to.
Yes. No reasons to hold back. Let us do and help you.
You don't even need to call my office. Go to the emergency room.
Yeah.
Well, how many times have we found patients not moving and they, my leg was swollen and now I cannot breathe. Like, buddy, good for the
Yes.
We're not going to waste
blood clots and other things that can be life-threatening, of course. Blood clots are very important. Recent travel or swelling in the leg and, sudden shortness of breath, that could be actually a sign of pulmonary embolism. Actually, recently we saw a patient in our ICU who was a former nurse. She's a retired nurse, but she had a PE in the past, a blood clot. So she started suddenly having symptoms, and she knew, I knew right away that was like another blood clot. And she was right. Yeah. So, but those acute symptoms, you're right, those can be life-threatening. So never stay home, because some people say, I felt this 3 days ago and I decided 3 days later, or my family brought me in, now I'm like semi-conscious.
This is why shortness of breath in particular, I like to classify it into the timing, because...
Yeah, I think that's a good way to look at it.
Yeah.
And for the patient itself.
Like I said, I'm always trying to rule out the things that are going to kill the patient.
Right away.
Right away. And then once you rule that, then you have a little bit more time to kind of work out the other stuff. Because it is a complicated workup. It's not something that you're going to figure out always in one visit. Sometimes it requires referral to specialists.
Thankfully, we don't have those times now that doctors think that once they get the diagnosis right away, they feel like, I know right away. I don't think this is the diagnosis you want to do that, because by having a narrow vision, you miss a lot of things.
Unless you see very clearly on an X-ray, you have a pleural effusion.
Oh, yeah, exactly. Well, that's the difference. But the acute things make sense. But talking about these old ones, they say, well, this is what this. You don't need a pulmonary evaluation because this. Right. Those are the ones who say, you know what? It's better to have a wider approach and then narrow it down rather than.
Right. I mean, once again, is it cardiac? Is it pulmonary? There's dozens of diagnoses in each one of your fields. But is it metabolic? Is it, are they anemic? Do they have a high
And we talked about, the GI and liver.
Right.
We nowadays, we have an epidemic in liver disease, which like fatty liver and then liver cirrhosis. And then there are complications actually of shortness of breath. It can cause, we call it hepatopulmonary disease.
I was going to say, there's a new diagnosis on that, like cardiometabolic kidney disease, where we involve now the liver into the whole axis of cardiac and renal.
Yes.
And we're trying the American College of Cardiology is trying to call for that. This works together. This is not
many systems work.
It's not an independent thing. All have worked together on this.
Yes.
The other good thing for the patients to know is that, the initial workup for most of these things is pretty non-invasive.
Yeah.
I mean, there's nothing to be really scared about.
Yeah, a little bit of blood work maybe, but an X-ray.
The only way for me to harm you with an echo is if I throw the machine at you. So this is an ultrasound, right? We use it on babies. Yeah. Right. There's no way for me to harm you. There's an EKG on that, and the stress test. Yeah. The stress test is a little bit different. That's because there's always a risk. What if I fall? What if? I get it, but we have good staff there with you. You're not alone.
Yeah.
But like you said, the basic thing is that I have to actually try to harm you with it.
Right. So there's no harm. It's more harm if you don't pay attention to your symptoms.
Absolutely.
Let it go.
Absolutely.
Yeah.
So thank you very much, and we hope to hear from you with any topics that you may want to hear. In regards to any other systems and any other symptoms, let's say. But I think this is very exciting for Dr. Mendieta and myself. No, this is our, bread and butter. We love it.
No, any questions that you guys receive, I'm more than happy to answer. And you guys,
that's great. And we do have an email if you want to send those questions in. It will be posted, but I will read it once again and let you know what it is. It is Prima CARE Beyond Diagnosis. PRIMACARE BEYONDDIAGNOSIS @gmail.com.
Okay.
It's kind of a little bit of a long.
But we'll put it in the comments somewhere.
It'll be there.
Yes. So
you can link it.
We'll link it. And let us know if you have questions. We'll answer those. If you have topics you'd like us to discuss, let us know, because we want to do this for you. Basically, we want to do this so we're answering the needs of the community. I want to always thank our sponsors, Bay Coast Bank, just right for all your financial needs. Visit baycoast.bank or call 508-678-7641. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. You can always support us by subscribing to us on YouTube and by following us on Facebook and Instagram. And that's basically, it'll be under Beyond the Diagnosis, and you'll be able to find that easily.
That's great.
Yep. And once again, I want to thank Ron Gamache for doing our intro music. And Ron's been a friend for a long time. He does a great job. And Prima CARE, your trusted medical providers in Southeast and New England. BioSkills of Northeast for producing our show and available to produce your show by calling 774-301-8811. And of course, Dr. Mendieta.
Thank you.
Thank you. We really appreciate it. It was a great topic, great talk. And really enjoyed it.
Yes. Thank you.